Hello friends, welcome to Medicine Made Easy. We'll continue our series of videos on approach to a medical condition. In this video, we will discuss the importance of proper diagnosis and treatment of patient who present with cough. There are so many causes for cough. So initially we need to uh, diagnose the cause for cough and later we will go through the treatment part. The most frequent cause of acute cough include respiratory tract infections like common cold, pharyngitis, acute viral or bacterial sinusitis, Bordetella pertussis infection, and the lower respiratory tract infections like acute or acute viral or bacterial bronchitis, community acquired pneumonia, acute exacerbation of chronic obstructive pulmonary diseases, asthma, allergic rhinitis, and rhinitis due to environmental irritants, and irritation to the bronchial tree by smoking, fumes, or chemical products. So, these are mainly the most common causes for acute cough. In elderly patients, acute cough may be a manifestation of left heart failure or aspiration. The less common causes like pulmonary embolism, foreign bodies, and bronchiectasis. Although acute cough results from a benign cause, chronic cough occasionally may be a manifestation of a life threatening disease. The most common cause for chronic cough include upper airway cough syndrome, asthma, and GERD. In history taking, the first goal is to check for alarm symptoms that require immediate attention. So, next is to determine whether the cough is acute or chronic. Like if the duration of the cough is less than 3 weeks, then it is called acute. And if the duration is 3 to 8 weeks, the cough is called subacute. A duration of cough more than 8 weeks is chronic. In the review of the symptoms, pay attention to the upper and lower respiratory tract, cardiovascular, and gastrointestinal tract symptoms. Ask about any smoking habits or environmental or occupational exposure and take a detailed list of current or prior medications. And review past history, including allergies, asthma, sinusitis, recent respiratory infections, tuberculosis, coronary artery diseases, and esophageal diseases. This is the flowchart. First, initially ask for the alarm symptoms like fever, productive cough, dyspnea, hemoptysis, and persistent wheezing. If any of these symptoms are present, go for a chest x ray. So, if there are no alarm symptoms, assess whether the cough is acute or chronic and review of the systems like RS, CVS, and GIT. Next, ask about the environmental irritants. If there are no environmental irritants, and ask for medications history and ask for history of allergies and CAD and then ask for the cough characteristics. Ask about the onset and duration of the cough, frequency of the cough, and change in the frequency over time. And ask whether the cough is dry cough or productive. If the cough is productive, ask for the consistency and color of the cough. And ask for associated symptoms like precipitating and elevating factors. Next comes the common and uncommon causes of acute cough. The common causes include acute bacterial sinusitis, common cold, COPD exacerbations, pertussis, allergic rhinitis, environmental irritant rhinitis, subacute cough, post-infectious cough, and pertussis. Less common causes are asthma exacerbations, pneumonia, heart failure, aspiration syndromes, pulmonary embolism, and exacerbation of bronchiectasis. And the common causes for the chronic cough include rhinosinus conditions, USES, asthma, non-asthma eosinophilic bronchitis, bronchiectasis, GERD, chronic bronchitis, COPD. And the less common causes like bronchiolitis, occupational and environmental causes, aspiration, bronchogenic carcinoma, drug-induced cough, tuberculosis, and interstitial lung diseases. Next comes the complications of cough. Respiratory complications like pneumothorax, subcutaneous emphysema, pneumomediastinum, pneumoperitoneum, laryngeal damage. Cardiovascular complications, dysarrhythmias, and loss of consciousness. Central nervous system complications like syncope, headache, cerebral air embolism, musculoskeletal complications, intercostal muscle pain, rupture of the rectus abdominis muscle, increase in the serum creatinine kinase, and cervical disc prolapse. GI causes, GI complications, esophageal perforation, others like social embarrassment, depression, sleep disruption, urinary incontinence, disruption of surgical wounds, subconjunctival hemorrhages, petechia, and purpura. So, if the patient presents with cough, so ask about alarm symptoms. If there are no alarm symptoms, so ask whether the cough is acute. Acute is duration less than 3 weeks. That is self-limited conditions like common cold, acute sinusitis, acute bronchitis, and pertussis. If the cough is chronic, evaluation for chronic cough like episodic wheezing is present, then consider asthma. So, if no episodic wheezing, ask for the nasal and throat symptoms. If nasal and throat symptoms are present, consider USCS. If no, then ask for the GI symptoms. So, if GI symptoms are present, consider GERD. If the patient is smoker, consider smoker's cough, COPD, or lung carcinoma. So, ask for any other symptoms and consider other diseases. So, if there is no identifiable cause, ask for chest X-ray, PFT, and bronchoscopy. Chronic cough evaluation. Chronic cough is a cough of duration more than 8 weeks. Take a proper history and do a proper clinical examination and go for a chest radiograph. If there is any evidence suggestive of lung cancer pathway, go through that pathway. If there is no evidence of any infection, then ask whether the patient is using any AC inhibitors or is he or she is a smoker. So, if patient is on AC inhibitor, stop and see for the response. And investigate and treat most likely causes like gastroesophageal reflux diseases, asthma, non-asthmatic eosinophilic bronchitis, rhinosinusitis, upper airway cough syndrome. So, if any of these causes are present, treat the cause. If there is complete or adequate response, no further action is required. Or if there is partial or no response, consider alternate diagnosis and do further investigations and ensure compliance and adequate treatment. Consider alternative treatments, consider cough hypersensitivity, and start on neuromodulators. And you can refer to a cough specialist clinic. Alarming symptoms to be considered as serious in case of cough. So, cough with hemoptysis, consider lung cancer, tuberculosis, pulmonary embolism, and pneumonia, which are the serious causes. While the benign causes include acute viral or bacterial bronchitis, COPD exacerbations, and bronchiectasis. In case of cough, fever, and purulent sputum, consider pneumonia and lung abscess. While the benign causes include acute sinusitis, cough with wheezing and shortness of breath, consider asthma, COPD exacerbation, and heart failure, which are the serious causes, while the benign causes are acute bronchitis. In case of cough with chest pain, the serious causes are pulmonary embolism, acute coronary syndrome, that is angina pectoris, and the benign causes are COPD exacerbations. In case of cough with excessive chronic sputum production, consider bronchiectasis, lung abscess, and lung cancer. And the benign causes are chronic bronchitis and chronic sinusitis. In case of cough with unintentional weight loss, the serious causes include lung cancer, tuberculosis, lung abscess. The benign causes are COPD. Cough, dyspnea, and lower extremity edema, consider congestive heart failure and pulmonary embolism. Post infectious cough. Post infectious cough refers to a condition that begins during a respiratory viral infection and lingers for several weeks after the acute symptoms gets subsided. So, patients with subacute cough, nearly half of them had a post infectious cough that resolved without any specific therapy. Treating the specific underlying cause. In case of asthma and cough variant asthma, bronchodilators and inhaled corticosteroids are the treatment. In eosinophilic bronchitis, inhaled corticosteroids and leukotriene inhibitors. In allergic rhinitis and postnasal drip, topical nasal steroids and antihistamines, topical nasal anticholinergics with antibiotics if indicated. In case of GERD, proton pump inhibitors or histone H2 antagonists and conservative measures like avoiding beverages. Angiotensin converting enzyme inhibitor discontinue and replace with the angiotensin 2 receptor antagonists. In case of chronic bronchitis or COPD, smoking cessation and treat for COPD. In bronchiectasis, postural dryness, treat infective exacerbations and airway obstructions. And in infective tracheobronchitis, antibiotics are required and treat any postnasal drip. In symptomatic antitussive treatment, neuromodulators only after consideration of cause. And in chronic cough, in all cases, speech and language therapy is required. Chronic cough affecting quality of life, amitriptyline and gabapentin, that is neuromodulators. Chronic refractory cough, we can go for slow release morphine. Thank you for listening. In the next video, we will discuss about the treatment of cough in detail. Have a good day. For more videos, please like, share, and subscribe.